So greetings, and good evening, good morning, afternoon, guys. I'm sorry, it's been a long morning. So welcome to Michelle Speaks. If you hide it, you can't feel it. I'm Michelle Portier, the host of the hour, and today we have a phenomenal um, team here to speak with you today about some things that are very important to the community, especially during this time where we are um, in the midst of two concurrent pandemics. First, the COVID pandemic, and then the greater pandemic of racism, which is the greater umbrella of that is like the lack of humanity or the humanity and inequality issues. So I had the opportunity to meet Dr. Kenyatta Lee and Mrs. Laquita Lee at a meeting that we formed to kind of address the issue of inequality and injustice. And in doing that, I was so impressed with what the leads are doing in the community that I just had to have them on so that we can have the crucial conversations. Because on Michelle Speaks, if you hide it, you can't heal it. We address things within the community that are considered to be taboo or the proverbial elephant in the room. So today, we're going to be discussing revolutionizing care in the underserved communities, among other things. And so, without further ado, I want to introduce to you my guests of the hour, Dr. Kenyatta and Mrs. Laquita Lee. Welcome, 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 welcome.
Thank you.
Thank you, Michelle.
Thank you for having us.
Good afternoon, everyone.
I'm honored that you guys are able to be on. So, what I want you to share with my listening audience is who are the Lees, personally, professionally, and spiritually?
So I'll start. So personally, I grew up, just to give you a basic overview, I grew up in Virginia. I'm not a Jacksonville native, but certainly I call Jacksonville my home and so excited to be here. I grew up in an environment where I was excited about science and math and had lots of really good exposure, had some tremendous mentors who supported me throughout my childhood. I can remember making a decision. I grew up, in fact, in a community very much like the one that we're in right now, in Newtown. And if I'm honest with you, Jacksonville feels a lot like, to me, it feels a lot like Richmond to me, but with an ocean. So it feels very comfortable to me to be in this environment. While I was a STEMmy. We're both sort of STEMmy people. Science and technology and math was something I really enjoyed. And the social consciousness that came with growing up in Richmond, Virginia in the early 90s, where there was that sort of, there's still issues that we're dealing, many of the same issues that we're dealing with now. My heroes were W.B. Du Bois, Carter G. Woodson, definitely Charles Drew, thinking about that, sort of thinking about those men and sort of the impact that they had on me. I went to college in New York. I went to Cornell as an undergraduate, and again was just really blessed to have great mentors, people who worked with me, who cared about me, and just given opportunities to grow and to study. Went on to medical school, and actually at Mayo, I was in Rochester, and I came to Jacksonville because my mentor, Dr. Willis, when I was there, I said, I love Rochester. It's an incredible experience, but I see myself working in an African American community. Do you think you can help me with that? And at that point, the guy said, look, I have just the thing for you. And he called Dr. Willis, and within a month or so, I was in a location here, and actually doing research and walking through the urban core. So my job was to do a study where I looked at zip codes 2, 4, 6, 8, and 9. And I went door to door, and it was in summertime. We were blessed with two things: lots of heat and lots of rain. And brave on both. And the community was beautiful. People would say, come on in, have a seat. They go get people that we do the study, we'd sit down, we talk. It was just felt really good. So when I graduated from residency, when I was in Philadelphia, I came here, and it was just natural. I worked with Ms. Means. It was a great opportunity, just professionally and personally. Had great mentorship. Dr. Stewart was my mentor. And learned a tremendous amount about community medicine. I always say that anybody who practices community medicine and doesn't go into the community is like a surgeon who practices surgery and does not go into the OR. It's just not possible. So we lived in the community. We worked. I was on 21st Street. I worked at Sutel for a period. I did that for about 10 years. And then professionally, I left Jacksonville for a period on a journey. It was like a journey. We moved in 6 years. I moved 8 times. We were moving.
Wow.
And the idea, of course, was that
The military. Yeah.
it felt very much like that. Oh man, it was.
But you came back home.
We did. It was a great experience, and we moved around. It was a quest for knowledge, quest for information, quest for learning, and it was an opportunity to just as a professional to grow. One of the things that and we'll talk more about this, but I learned through my studies as a medical student was the idea that disparities were real, and I got to really on a first-hand basis see the population that was being impacted by that, and then I got a chance to actually practice in the community for about 10 years. And what I learned was that disparities can be eliminated with quality. So it was not just a big social issue. You start talking about social issues, but it was a social issue that had a solution to it. And so I left here, I went to Tampa, I worked for DaVita Medical Group, and then I went to UT, and I was their chief quality officer for about 4 years. And I got to really learn how to be a general manager, how to grow a team, how to manage, and how to really put things together and not just talk the talk, which I think there's a lot of really effective pontification, but to really take that and turn it into action. So we're, of course, we don't talk more about it, but personally married. We have 5. We've been married for what, 20 years, and we have 5 beautiful beautiful children, and just enjoying myself. And here now coming back from Texas to Jacksonville has been a great experience. So to be back here, we never sold our house, so we always planned to come home. And so we're here with the family and the crew. And so I'll let Laquita.
So your quest for knowledge was ultimately to bring that knowledge back home, right? The community.
Great big old bag of goodies. Oh, it was such a good.
Right.
It was rigorous. People use that word, but that word we experienced rigor, like it was just amazing. But it was good to be able to get the learnings, because to me, population health management is a specialty, and it is a special skill that it's complex, mostly in the sense that it's not technically complex. The hard part is the human part, where you have to have the emotional intelligence, management, leadership, financial, IT. It's such a hodgepodge of things put together, all designed to produce the best outcomes possible for the population that you serve. And that's what we're here to do in this space. So we'll talk more about it with the other questions and all, but
right.
Absolutely.
And so thank you so much for telling us who you are, Miss Laquita Lee. Did you want to add anything to that, or did he tell it all?
Well, I'll tell you about myself. I was born and raised in the great state of Texas, which is why we ended up back in Texas. God finally answered that prayer many years later. So we got to be there for a few years, and that was a great experience. So, but I was born in Houston, and there were 5 children. I was child number 2 of 5, and single parent home at the age of 13. So I was raised in a home with a very strong woman who was raising 5 children. I had a lot of responsibility for that reason as well, since I was the oldest girl and child number 2 out of 5. So we moved around quite a bit growing up, and so I had a diversity of educational opportunities. So going to schools in the urban core as well as in the suburbs. I got just a wealth of knowledge and training. So I too also grew up in similar communities to where we are. A pivotal experience for me in my matriculation was in 8th grade, where I went to Crispus Attucks Middle School, and there the teachers basically just wrapped their arms around me, took me in and exposed me to different opportunities and programs that I might not have otherwise been exposed to. So I was participating in different math and science competitions. I did the science fair, which was actually my first exposure to healthcare. My science fair was taking blood pressures. So I didn't know that many years later that I would end up doing that more regularly. But as well as that, I was able to participate in a program at a private school. And, at that time, affirmative action was still in place, and there were a lot of different programs that were geared towards educating minorities and giving us opportunities that we would otherwise not have. And so I had to test. So I had to test for this program, and it was a summer program where we would take math and science and different engineering courses just to enrich our education and expose us. And it was 3 summers, so they bust us out. Just an awesome experience. Ended up
Right.
being at that program with some of the same students that I would go to high school. I graduated from the High School for Engineering Professions, which was at Booker T. Washington High School in Houston. And so, but at the end of that, they had a select few opportunities to have internships. And so I was blessed to be able to be one of those students chosen to intern at Amoco, Fortune 100 company. So that was the summer after my junior year. And then I was able to do part-time as well when I was in high school. But in high school, I was in social clubs. We had our pledging experience. I was in the band. I was drum major. So I was able to just have that full experience of
Right.
in the engineering program, as well as being able to be involved. That's why I discovered my passion for dancing was at that time in high school. So just it really taught me the value of giving back, to the community and just having different opportunities. So I ended up being blessed to have a full ride to Florida A&M University. So I went there and I graduated with my degree in electrical engineering. And at the end of that, I was able to have 10 job offers because we had an awesome career center that would have 300 plus companies come every fall and spring. And we would just be able to have that, especially as engineers. Our program is unique that we share it alongside FSU. And so that was, we were right next to each other in the class. And so it was just an awesome experience, from the two different academic centers to come together and to learn side by side. And so I ended up being able to go back to Rochester and join my husband and work for IBM. We had our first child my 4th year. So, and I pursued, I kept on and I finished, I finished my degree on time, and so we had a child early, so it was a great opportunity doing that. And so that leads us to here. We came here, and when I was younger, I always said I wanted to be a doctor, but ended up pursuing the engineering route. Because the other thing I always said is I'm not going to be one of those forever college students. I'm going to pick my major, I'm going to stick with it, and I'm going to finish.
You're going to be a professor, right? As some of us have been known. Right.
So I made sure, and when I realized that doctors had to go to school for 8-9 years, I said, I'm going to stick with the engineering. So for me, I always wanted to have a life and have family. And at that time, how it is in school, you want to start making some money. So so I was happy to graduate and get the job with IBM and I started my career as a software engineer. So I actually worked as a software engineer. We moved here. I actually stopped working for a little while and was able to take care of the family, which was a blessing. And I ended up teaching for a couple of years, which is a really great experience. I was able to homeschool and then I taught. And so speed ahead to today, I decided to go back to school, and I have my national certification as a medical assistant. So I thought it was very important when we started talking about, opening up the practice and doing this together as a husband-wife team. I thought it was important that I go and get some education. So as a medical assistant, you get the best of both worlds. You get some of that office business side as well as the hands-on side in the back office where I'm able to actually assist him. So I
Right.
finished that program here, and I'm certified now, and we're just excited to be on the campus of Edward Waters College, another historically Black college. So for me, being at FAM, I have a love for our HBCUs and the diversity.
Right.
So we're just conveniently poised to be here to be able to give back to the students here and to share some of the experiences that Kenyatta and I both were given as we grew up to be able to
Right.
share here on this campus. So we're excited to be
It's
in the community. What'd you say?
we're excited. I said we're excited to have you back in the community. And, for my listening audience, you can definitely hear from their background about who they are personally, professionally, and spiritually, that they are more than equipped to be an asset to the community and more than equipped for us to have the conversation that we're going to have today regarding healthcare disparities. Because when we had the original conversation that led to you being here today, again, it was in a meeting where we were trying to address and figure out how we were going to come together as community leaders, not bemoaning, the color, and how we were going to come together to address some of the needs, especially targeting those that are in the vulnerable population. And the biggest thing the first thing that came to mind was the health disparities. And so I wanted you to share with our listening audience first, why Pareto, and I hope I got that right. And then define disparities and share, with us what the impact it's had on the underserved and vulnerable populations has been here locally and nationally, as I'm sure you can speak to that as well.
Michelle, that's a great question. So Pareto is really the Pareto principle, and we named it after Vilfredo Pareto, which obviously he was an economist and sociologist. And what he looked at was the idea that 20% of an input produces 80% of the output. When you look at populations, so when you look at a population, 20% of that population is really producing probably 80% of the morbidity and the suffering that happens within that population. Most primary care practices are structured to manage very well that 80%. That is to say, they do a great job. If you were to stratify your patients and say where are the sickest patients, that's going to be 20%, and your least sick patients are going to be your 80%. So it's going to be patients who have colds and scrapes and bumps and lumps and things like that. They need prevention. They need vaccinations. Well, what happens is when you're in a primary care practice, I watch this happen for 14, 15 years, is when a person comes in with what happens is you come in with a new diagnosis of diabetes. You have a sugar of 600 or 700. That's a catastrophic diagnosis. You come in with a positive screen for cancer. So you have breast cancer, or you have colon cancer, or you've had a stroke, or you've had a heart attack, or you have congestive heart failure. What you see is that the practice is well designed to manage those sort of acute instances of disease. But they struggle when it comes to managing these more complex issues, which produces tremendous suffering for the patient. So Pareto is really a practice that celebrates the idea that, yes, we take care of that 80% of issues. So we'll take care of your scrapes, your bumps, and your rashes, and we'll do your screening, and we'll fill your prescriptions for blood pressure and sugar medicine, and take care of your thyroid. But should something catastrophic happen, we have systems in place that are really designed to make sure that you have the ability to coordinate care across the entire healthcare ecosystem to produce the great outcome. So one of the things that you see is this word value-based care, where now we're moving away from the value. The focus is not just value, how many did you see, but how well did you see the patients, and actually having ways to measure that. So one of the quotes that I loved is this idea. I think Churchill said, he said that Americans will always do the right thing after they've exhausted all other opportunities or possibilities, which I think we may see that with this pandemic. But what you're seeing that is in healthcare, Americans, which we have the most sophisticated healthcare in the world, bar none. But what you're seeing is a gradual evolution of better systems to produce better outcomes for the patients and the communities that we serve. I'm going to talk about the disparity issue. Disparities are the quantitative differences that exist between populations based on specific issues. So, there's when you look at specific disease issues. So, when I say quantitative, just the numbers. So, the percentage of the patients who have diabetes, or say we'll compare Orange Park to the urban core, and looking at that statistic, and it's usually something related to some socioeconomic variables. So Black, African American versus white, Asian versus Hispanic. Those not versus, but just understanding the differences between populations. And what I did when I was a student was I looked at I studied disparities a bit. And what you realize is that there are three ways that disparities happen. They happen because of the patient. Not that they want these differences, but they make decisions, right? Whether they smoke, whether they drink, whether they understand how to manage, they learn, and those types of decisions, and their willingness to seek care. That's to the patient. Then there's the provider level issue, where providers have the ability to influence the trajectory of care based on their behavior, how they interact with the patient.
Right.
With love and relationships, do they have a good bond? Can they communicate with one another well? And then there's system issues, where the system itself is designed to do something very different, then it doesn't produce a good outcome. So we have a primary care system in this country that is exquisitely well designed to do acute issues: bump, a lump, a scrape, a rash, an infection, bam. But when you look at complexity within the chronic disease, that's longitudinal. Diabetes doesn't go away like a bump or a lump or a scrape. Hypertension doesn't do that. So when we look at the costs in healthcare, and this is a Pareto concept, almost 80% of the costs are related to those chronic conditions. So what you see are differences in outcomes between those two, differences in outcomes within the African American community that are just across the board, that are actually those disparities exist, and they're pretty prevalent. And a lot of that has to do with the systems of care that they get access to. And so being able to change those systems of care allow you to really actually eliminate those disparities and minimize them very greatly within populations and within the communities in which we're providing care for.
So is it also that there's lack of access of quality care, or is it also that there's a combination of that and the system being broken?
It's a lot.
As it relates to chronic versus the acute issues.
It is. It's not as many healthcare centers. So one of the things that you'll see we're excited to be here at EWC in the urban core is because there is almost a healthcare desert. We talk about deserts when it comes to fresh fruits and vegetables and things like that, and they're working on those things. But actually having more providers, and there's a correlation between the density of primary care, meaning that in some communities there's a doctor on every corner. We have other things on every corner, but we certainly don't have a doctor on every corner. So actually having the more physicians you have, there's a correlation. So that disparity is there, and there's all sorts of social determinants. Whether is the population insured? Do they have access to insurance? If they're insurance, do they have co-pays that they can cover? I mean, all the sort of things that they call that the social determinants. Those societal factors that will determine how we engage care and access care. So that makes a huge difference.
Right. So what have you seen since you've been back here in Jacksonville? Because you've been doing this a long time, obviously. So what have you seen that has been the greatest issue, or that's impacted how you have been able to serve the community due to the current climate because of the pandemic and the other issues that we're having locally? What are some of the barriers to those that are in that underserved or that vulnerable population getting care or getting access to the care that they need?
I think it's mostly the density of practices. It's opening. So what I've seen, and part of why we're here, is the idea that we just don't have enough primary care practices in the community. And so being here, when I look around, I think that the thing that scares me the most is that there's so very few physicians in the area that we're in. And so and that's a major issue within the community. So It's just the density. There are a lot of other issues, but I think that's one of the issues that concerns me, and that's certainly something that we can do something about.
Right. And do you think that's by design, or do or that um, the primary care physicians or the general practitioners just aren't inclined to want to serve those populations?
I don't know. I think people tend to practice in communities in which they feel comfortable working in. I think there is a tendency, there's a small percentage of African Americans that are in medicine. Less than 2% of the people in the country are physicians. That number is too low. And there are just not enough people who are experienced and feel, deeply comfortable. And then the payer mix is different. You have a payer mix. There's a traditional desire to be in commercial-based populations. Although we have commercial, there's mostly social payers, so Medicare and Medicaid. And so for us, we're agnostic to that payer type, and we're more interested in, can we serve the community? Can we love the people in this community, and can we make sure that we work with them in a close partnership to produce better outcomes? I practiced in this community for 10 years before I left. And I came back. I practiced maybe 7 minutes from where I am right now in Sutel. And provide it to me is home. And it feels good to me. And you're going to be dealing with payer mixes that are not the traditional. If you want to see, lots of commercial and stuff like that, this is probably not the location. But if you want to take care of some good people, to me, that are the salt of our community, the bread and butter, the people who sent me to college, who stood up and made it possible for me to get into medical school and stuff like that, then this is where that is. It's a challenge, but it's the right challenge, and it's enjoyable.
I know you mentioned in our previous conversations, one of the things that inspired you to want to address the health disparities, because you said your father was a veteran, so thank him for his service. And one of the challenges that you had, and one of the issues that you had, was the lack of the quality that he received. Can you speak a little bit more about that?
It disappoints me when I think about my dad and what happened to him over the trajectory of his disease and his presentation. My dad ended up in a situation where he ended up on dialysis. And it was a lot of what you see in healthcare are preventable issues that have managed effectively and correctly with the correct systems of care. Not just intermittent and episodic care, you can produce better outcomes. So, and even when my dad, we would have to travel up and fight. We would have to advocate. One of the things that you'll see in our sort of description is we'll advocate for your health. As a physician, I had to advocate to make sure that my dad was taken care of well. I had to call the physicians. I had to engage them. I had to ask them questions. Did you do this check? Did you check his hemoglobin? There are a lot of things I had to do. The last time he was admitted, I said, hey, we need to do dialysis. He's fluid overloaded. He bounced back. He had to readmit. There are a lot of things that he needed. He was a complex patient. I think his primary care infrastructure was good if he was not too complicated in basic stuff. But as soon as he started to get into the hospital, he went to a sniff, his kidneys started to drop. As soon as they fumbled. In fact, I didn't really engage his primary care physician not one time. Was he actually involved in what was going on with my dad? And it just reminded me that I want to be the type of physician, and Laquita and I want to create the type of company and the type of practice that is longitudinal. That if you hit the hospital, I'm in there. I'm advocating for you. I'm talking to the specialist. I'm advocating on your behalf. People are sick. They're scared. There are complex issues with their family. Some might be intubated or ICU, all sorts of stuff happening at the same time. And actually having a primary care physician, like in the old days, because in the old days we used to go to the hospital. In the old days, we'd show up with a little bag and we'd sit in the doctor's lounge and we'd talk about Miss Jones and Mr. Smith. And now we're employed and we're, very finite, 8 to 5. We're kind of bringing back some old school practice models where we can do these things. So that's a great question.
Okay. Yes. So thank you for kind of expounding more on why you're so vested in addressing the health disparities within that population. One of the other things I believe contributes to that is as a people, we are less inclined to go get care if we feel that we're not being listened to, if we feel that, you know, even though we're sharing with you what is wrong, we're not seen as individuals. We're seen as numbers. And after a while, you just stop going. And so how are you going to be able to address that? How are you going to gain the trust of those in the community? And I
That's
know you grew up here, but for those that have had some bad experiences, especially during the pandemic.
that's a great question. I mean, I like that question. So the biggest issue is sort of the respect dynamic, and the frustration. And I will tell you that frustration, we have the greatest care in this country, in the world, but we don't always have the best systems. And
Mhm.
that is not specific to African Americans, that you don't have great communication. It is something that disparities, even it's worse, it's exacerbated in our communities, just because of how things are structured. There's a power dynamic, doctors and things like that, that can be stressful. The communication can be different. Sometimes the languages are different, and that can exacerbate it for sure. Across the board, you see that we struggle in that type of that sort of patient-centered communication is what they call it, where you're focused on the needs and the experience of the patient. That's the challenge. One of the things that I was trained when I was at Mayo, and Mayo would say this, and they have it on everything written, is that the only interest is the interest of the patient. That's it. Not your shoes, not your car, not your credentials, not what you're going to eat for dinner, not where you're going to go vacation. Focus on the patients that you have the honor to serve, and take care of each and every one of them with that mindset. So for us, is making sure that we get to know our patients as human beings, in a very longitudinal, substantive, meaningful way. And all of the apparatus that's around them, their sisters, their cousins, their daughters, the entire care
Right.
delivery team, their neighbors, that they're going to be key players in their care. Um, and love. I mean, the whole idea. Laquita is my chief operating officer, so I'm this CEO and CMO. I like to say CMO is the chief mop operator, chief mop operator.
Right.
So we do a little bit of everything. But
So you go ahead.
so she does
Go ahead.
that as the operating officer. It is the idea of operationalizing love, to take a system
Hmm.
of care where
Oh,
you're serious about working with and caring for the people that you have the honor to take care of. So, and being very intentional about that, and creating a space where people can feel comfortable, they feel safe, they feel relaxed, and they feel like they're being listened to.
We want to create an environment. We want to create an environment here when the patient walks in, they just feel better the moment that they walk in the door. We want to feel like
hmm
the load has been lifted, that they're healthier,
hmm
that they're just gonna feel better. So the love is key. The love is central, and just building that relationship and partnering with them to help them achieve their goals. So our goal is
Right.
to help that 20% to live longer, to have better
Right.
outcomes, to be healthier. And so we're going to do that by partnering and working with them hand in hand. When they are in positions where they may have to be at the ER, like Kenyatta said, we're going to be working with them. So
Right.
they don't always know the questions to ask, or
hmm
to make sure that certain labs or tests are done.
Mhm.
So we're going to
Right.
make sure that we are hands on, with
hmm
our clients who come through that door, and that they know that they're just going to get quality care when they come to Pareto.
So I love what you said. That's wonderful. I love what you said about operationalizing love, and you said you're going to address it like basically holistically, getting the entire family involved. Because what I've seen and what I've even witnessed myself in the healthcare system is that often the family is not included or the family is not involved. And so and sometimes the patient, depending on the severity of whatever their ailment is, they're not even articulating. So I think that's really wonderful that you're bringing that holistic, um, the whole healthcare back into the process of helping them be healed. And the fundamental foundation of that is love. So that's wonderful. And so I really love what you guys are bringing back to the community. And so my other question is, what is your vision for the Shell Street Community Resource Center? Like I know you partnered with the Shell Street Center to bring that back to that community. And then actually that's whole health as well, because they can tie into some of the services that the Shell Suite offers. So share with us what
You
your
know,
vision is.
part of the reason we came here to work in the Shell space, there are a lot of reasons. One, I love the fact that we're connected to EWC. It's an academic institution. I have been a professorial type guy, pontificating, writing papers, and adding rigor to understanding disease. Just I love that. This stuff is just enjoyable. I love to teach it and talk about it. But I also like the comprehensive psychosocial model, the environment that is here at the Shell Suite. So my practice, I actually have a contract with the city and with EWC to provide services for the community, for the students, and for the staff. That's the expectation. That's my charge. Being here it's not it's more than just being in a building. I could be in any strip space and have my practice, but to have the relationships that we have, working with Miss Marie Heath has been incredible. Being in a position where we can work together, and they have all the different components. So they have social workers. They can help with food. They actually feed over, was it 200 or over 500 families on Tuesdays and Thursdays, which makes a deal. So you talk about food insecurities, people who are struggling with their diabetes, not because it's because they can only eat certain food. They just can't afford the foods. And so providing nutritious foods, helping with their bills, helping with other resources, which I think makes a difference. So having that comprehensive environment, actually the telemedicine piece here is amazing. So actually having a full suite where they actually have the ability to work one-on-one with the seniors to do telemedicine. So when you think about Pareto, we're looking at using different modalities, and one of the whatever sort of a by any means necessary sort of approach. And so part of what happens with COVID, as bad as it is, it sort of changed this sort of our thinking about primary care from the perspective of, do you really need to come in? And can I engage you effectively and meaningfully? And then do I have an apparatus that that teaches you how to use that phone and to use that computer in a way that allows you to seek better information for your own self-management, but also that I can communicate with you. We actually have a telemedicine suite in our office that actually has the computers. We have the cameras. We can do all that stuff. It's quiet, so it's not a people noisy walking around. And we'll also have an apparatus by which we can do a Pareto telemedicine physical that will include not just a face-to-face kind of a a Snapchat type thing where you kind of just talk to me, but I can get your vitals, like your blood pressure and your I can check get your pulse ox and your weight and all those things, because I have that instrumentation. And so our communication there's some data involved in how I communicate with you. So that's something we'll be working on. So the Shell Suite Center is indeed a blessing.
And that'll be secure, right? And their information, it'll be secure.
Oh, very secure, very secure. We're using Athena as our EHR platform, and we'll probably use their telemedicine platform, which is actually HIPAA compliant, or there's another one we're with Ring Central, but that's also a HIPAA compliant system in which we'll use to communicate as well. So there's a lot of sort of how do we protect that patient health information and do it in a way that's federally correct based on the regs that have come down.
Awesome. So for my listening audience, as you can hear, we have some phenomenal resources that are coming here to the local Jacksonville community, especially in the underserved and the vulnerable populations. So make sure that you take down the information that you see scrolling across the bottom of the screen, because I know those that are listening, you have loved ones, you have friends that they have ailments, but they're kind of hesitant to go and get the care that they need. Well, now we have something that can address those needs, and if needed, it can address it virtually, so they don't have to leave the comfort of their own home. And so I want to thank you, Dr. Kenyatta Lee and Mrs. Laquita Lee, for what you're bringing to the local Jacksonville community. One of the other things that I wanted to ask is, what do you think has been the secret of your success? And from the inception, the dream, to manifesting it, and to even you have a grand opening coming up, and I wanted you to talk a little bit more about that. But what do you think has been the thing that has kept you going? Because I know it's been challenging. And so what has kept you going?
Well, persistence, so when you have a dream and you have to, God said, write a vision down, make it plain. You need to write it down. Right. So when you have that dream, you have to write it down. You have to keep thinking about it. You have to keep dreaming about it. So persistence, and not letting that dream go. And so when you think about the goal and what the reason and the purpose is for what you're doing, that will keep you going. So it may not come today, right? It may not be a right away thing, but as long as you are persistent and you are consistently working on it, it will come to pass. And so this is just a blessing. It's been a long road. We started this, I believe it was it might have been April, I think, the process, with the road here to the Shell Suite Center. And of course, I got the vision of the practice, 4 or 5 years ago. So, it hasn't been an overnight success type story. However, you know, he never let the dream go. And then, we shared in that dream and that purpose, and we came together and things just started moving along faster. So, we got the contract and then COVID hit. Well, it just opened up opportunity just to give more time to do what we need to do to have everything in place,
Right.
for the community here. So you can expound on that.
I think that's key. Sort of success in this space is persistence. It's the discipline around choosing a goal and sticking with it. It's narrowing your focus. Jim Collins talks about good to great. He talks about this concept called the hedgehog concept, and that is the idea that what are you passionate about? And we're passionate about being home, passionate about being in a community that where we are able to serve the community and honor and be honored, just enjoy ourselves. Just to me, that I'm very passionate. And I'm passionate about eradicating disease and I used to ask my MA, did you feel that feeling? She said, what feeling? She said, well, I've been stomping out disease. I'm shutting out. I'm doing what needs to be done. So enjoying that idea that we are able to share information and ideas that makes people healthy and produces a different trajectory, because my dad is my dad. He's a human being. He's not a number. And he's a valuable asset to me, to my children, and to my family. And every birthday, every graduation, every phone call that he has with me is precious. And if I can get them more phone calls and more value into the community, to me, that's something I'm very passionate about. So those things are sort of essential to the success and just having a vision. I remember the idea of Pareto. Actually, I remember where I was. I was actually 18 years old. I was at the Medical College of Virginia, and I was walking down the street, and it was almost like something that I said, I looked at the hospital, and I hadn't had the best experiences with the hospital I was working at, and because it wasn't the best experiences. And it was not, they weren't overly rough, but it wasn't the best experience. It could have been much better. Could have been more respectful. Could have been more caring. And then I just read a book. I had this rule where I go to the medical library and grab a book off the shelf, and I would look at it. I look at it. I didn't know what the words meant. I didn't know everything that was there, but I grabbed this Mayo Clinic book off the shelf. And the Mayo brothers came together and created this clinic with these nuns. And it was amazing what they did. And I said, man, God, if I could do something like that. But then I looked at the hospital, I said, it looks so amorphic and complex. How can one person understand how all that stuff works? And I've spent 20 years, being just fumbling through. I went back to school, got my master's from Duke, did all that stuff. And then to me, working with Ms. Heath, meeting good people like yourself, Michelle, like-minded, the blessings that come from that, working with Miss Means, working with Dr. Stewart, having mentors, people, when you have a thing, then the how is like the creator takes care of the how. And and that's where I am. So the secret is hearing that voice and not dulling it. Don't numb yourself to it. And to where that secret or dark or light place where it may lead you. But it will, that's where we are right now. But it takes
so how thank you so much for your dedication and your persistence and your diligence and your fortitude to stay the course, because I know that you're going to impact the lives of so many people that have lost hope, about maybe even getting a simple ailment addressed, but let alone, those that have complex issues. So I know one of the things that you're going to be doing is restoring hope and honestly providing healing to many people that need it, and especially during this pandemic probably otherwise would not receive it. So I'm just eternally grateful that our paths crossed. And the question that I had is what is the meaning of Pareto, and why did you end up with that name? Why did you choose that name? What is that? What is the meaning, but the significance behind that?
So Pareto is the idea that it's the 80-20 principle. It's the idea that we built this practice. It's why do people drive SUVs? They drive SUV, and I'm going to say this, and it sounds kind of, work with me on this one. It's a big old car, and 80% of the time, you look at a person in an SUV and say, "What are you doing?" It's too much car for what you probably should be. But you drive it because if you live up north, and in 20% of the time, you will get a snow that's enough that you end up with 3 or 4 feet of snow, and that person in that SUV is still what? Still driving, still moving along. And you're like, well, I get it. I get it. Or if here in Florida, you get a rain and the water rises and the road is washed out, and you see that person that's almost 12, foot and a half above the ground, and they're cruising over it, and your car stalls and it cuts out. Well, so Pareto says 80, it's the 80-20 rule. Most practices are really great at the traditional bread and butter stuff. I get it. But we built this practice almost like an SUV's built. And that is to say that no matter what happens to you, we can take care of the full spectrum of issues that you're going to be presented with. If my dad was in an SUV type practice, they would have caught his creatinine before it began to drop or when it began to go up. If he was in an SUV type practice, somebody from his practice would have called that hospitalist or those specialists that were taking care of him to understand with his first hospitalization what was happening. Why was he anemic? Why was his creatinine going up? What can we do to work with Mr. Lee and my dad so that he could get a better outcome? So the Pareto principle is really the principle itself that says that it's the 20-80 rule. And I'm a quality guy. So quality, you're going to see Pareto in quality because it's a Lean Six Sigma tool that we use to find the truth. And if I'm honest with you, it is the most elegant mathematical representation of God force, sort of the creator's force, in large sort of randomized population. Sort of when you see it, is so elegant that you would think it would just happen randomly, but it's just beautiful to see that 20% of the time these inputs will produce that output, and our practice is designed to deal with that. So we use that Pareto principle as a basis for our name, Pareto, which we really like. So it's a weird, I love it. It's a strange name, but I like it. To me,
well, it's peculiar, but we are peculiar people for those that are following after the Lord. So I wanted to share with my audience, my listening audience, 2 takeaways that they can take away from this conversation that they can, implement, and then a call to action. And then I would like you to share how they can get in contact with you and anything else you want to share about what's coming up with Pareto Clinic.
So I'm sorry. So the takeaways. I think are engage your primary care physician. If you have a PCP, go to your PCP and engage him frequently. And I'm not saying that everybody should come to Pareto. We don't have, obviously, we can't take care of them, not yet anyway. But it is, if you're looking, but you should have expectations. You should have expectations. You should have a sense of, if you're struggling to get refills, and if you're struggling to get people to call you back on time, if you're sitting in the waiting room for 13 hours, that kind of thing. When something massive and catastrophic hits, you're probably going to struggle as well. So you want to be thinking, okay, is this the right environment? And the other call is, if that's not the right environment, feel comfortable. We're here for second opinions and everything else. So make sure that you engage your PCP and that you're looking for the right type of care, and that you have a good relationship with your physician, that you can talk to them and laugh with them and fuss with them. Sometimes obviously you're not going to fuss at them, but they may fuss at you. That you're in an intimate relationship with them, sufficiently intimate that you care about one another as human beings. That's always been the case in primary care. It's always been that way. And if you're not in that situation, if something hits, it's going to be hard for you to sort of then go from this type of situation to something that produces great outcomes for you. Any other additional?
Well, I just like to add just what he said. Be proactive. Be proactive in your care. Ask good questions. Don't be afraid to ask questions. Don't wait, until it's too late. So if something doesn't feel right, pick up the phone. Go to the clinic, go to the urgent care, and just be proactive and taking charge of your health. Um, Wellness is important. And so that's something that we will be incorporating here in the clinic as well. Just eating proper foods, whole foods, um, as clean as possible. So I would say those things. We are situated, as Kenyatta said, on the Edward Waters College in the Shell Suite Community Resource Center. So the address is 1697 Kings Road, suite number 1. So we'll be open starting August 3rd. So call today. We are taking appointments. We are accepting new patients, and we'd love to see you here. So our hours will be Monday through Friday, 8 a.m. to 5 p.m. So again, at the Shell Suite Center on the Edward Waters campus. And the telephone number you can see across the bottom, but if you're just listening, it's 904-478-5483. And an easy way to remember that is just 478-LIVE. We all want to live. So if you can remember that, you can reach us.
And we do all want to live. What I would ask of you is to speak to that person in the audience that's listening now that has tried to advocate for themselves and have met a brick wall, and they're just weary and they're tired and they've given up. What would you say to that individual right now that's tuning in?
Wow, I think that's a great question. You have great questions, Michelle. I think it happens. Medicine is super complex. And then the system of care is complex because you have a disease that's getting you, that's a challenge for you. And then there are financial challenges. And you have to, so that's the key. So if you're kind of solo by yourself, it's hard. It's almost like it's like doing law without a lawyer. I'm just going to be honest with you. So if you're looking at something as complex as the law system, you need a great lawyer. And in medicine, your primary care physician is your advocate. He is that person who works with you on your behalf, who understands you, who is able to connect you to the entire healthcare apparatus. He talks to the cardiologist for you. When I was at Mayo, the primary care physician and the specialist would be together. They would literally go upstairs and talk to one another. They would pick up the phone and say, hey, what's going on with this? She's taking this. And they would look at the entire, if we write this prescription, she can't afford that. So let's write this prescription. If I order this test, oh, we already did that test. We don't need to do this. Let's do this other test. So I would say, look, make sure that you get as much information as you can. Hit Google, but use good sources. Be careful because there's sources that are not all good on Google. You can get in trouble with Google. So making sure that you use good sources, and then find a partnership with someone who can advocate for you. Hopefully it's your primary care physician. Maybe it's a nurse in the family. Maybe it's someone like that. You can get clarity around what's happening with you. If it doesn't feel right, don't give up. And don't take if it doesn't, and you get to make a decision. You as a patient have rights, right? You sign those rights. Those rights are communicated to you in every office that you walk into. And part of that right is that you be treated with dignity and respect, and that you don't agree. If you don't, it's your body. If you like it, great. But if you don't agree with it, then you can say, no, I'm not going to do that. But I'd like to try something different. What do you think? And it should be a team relationship. With the relationships that I have with my patients, we strategize. This is what's going on. This is what I think is happening. These are the different things. This is what I think. What do you think? We talk about it. Well, talk to my son about that, or talk to my daughter about that, and we strategize and we come up with a solution. Sometimes patients will say, you know what, I don't want to do this. I'm comfortable with this being this, and I'm this, and everybody in the family knows what's going on. And there's some heated discussions. You know, families are really intense about these things, but that's a rich discussion. And so I would say, put yourself in a position where you have a strong advocate, somebody who can work with you and make it plain, and do your research. Make sure you know your stuff so that you can make sort of informed decisions about what's happening with you. So that's important. Don't give up.
Yeah.
Yeah. Thank you so much for sharing that. I wanted to share with you one of our guests that are on our listening audience said that they loved the statement that you made about pursuing determination that dreams um, that can change systems. So I want to say to my listening audience, if you've heard nothing else, hear the Lee's heart when they say that you will be treated with dignity, you will be treated with respect. They're going to include all of your family members, and you're going to work together to strategize or formulate a plan that is best for your overall health care, not just focusing on the one system, but determining what are the other contributing factors. And so again, I wanted to thank the League for agreeing to come on and share with us how they are addressing the health disparities in the underserved and the vulnerable population. And what they're doing, they really are revolutionizing healthcare here in those underserved and those vulnerable populations. And they're doing it on the fundamental foundation of love, which is what we're all called to do. So thank you guys again for agreeing to come on and share with us. Those that are listening in, be sure that you take down this information, visit them at the Pareto Clinic, come and join in for the opening, which is August.
We
If you're here in the local area,
we open August 3rd.
August 3rd, and you'll get an opportunity to come and meet them in person. So again, reach out to them at 904-478-LIVE. Again, that's 904-478-LIVE. So I hope you all have enjoyed what you've heard today. I hope it's been a blessing to you or to someone else. Please share this information with your friends, your families, your loved ones, even your frenemies, because they deserve good health care too. So thank you guys for tuning in. Thank you again, Dr. Lee and Mrs. Laquita Lee. And I look forward to seeing you guys at the opening.
Thank you, Michelle. We appreciate the opportunity to share with your audience.
So for those tuning in, join us next time on the show. Please, if you hide it, you can't feel it.